Hi, doctor.
Hi.
So
Hi.
it's auto recorded. We will
Okay.
wait for others to join.
Sure, sure. See, if no one joins also, we'll keep the recorded session and circulate it with them.
Yeah, sure,
And
sure.
if the parents want to type, they should type it. I should tell them to type it in the chat box, right?
Correct, correct.
Okay. And I will be able to see it.
Yes, you'll be able to see it.
So, will they video on, audio on, or can we control all that? Like the audio, can we mute them?
We can mute it. We can mute
Okay.
it. Okay.
Okay.
So, until there is a, we can mute it manually, doctor. No problem.
Okay. Okay. Fine. Will you be making us also host?
I'm just checking that, doctor. I'm just
Okay.
checking that. Yeah. Dr. Janvi, you're the host now. Are you able to manage it out? You and Dr. Namrata have made the host.
Both of us are the host, right?
Yeah.
Okay.
Am I audible?
Yes, ma'am, you're audible.
Okay.
Yes, doctor, you're audible.
Dr. Shruti has to join, and I think,
Parents have to join.
no, even she needs to be made co-host, I think.
Is it? I'll do that.
Yeah. What about Vinita, January?
I told them I will remind them.
Yeah. Because whoever has to speak will be will
Okay.
have to be. Yeah.
This is Shruti, ma'am.
You're able to make host to somebody, Dr. Namrata. Can you try out once? Are you able to
Uh,
make host somebody?
okay. How do I?
When you go on the window, right?
Okay.
Say for example, abhi everybody is a host. So, anyways,
Okay.
if you go to a window, there will be an option. There will be three dots. From that,
Okay.
you can select make host as an option.
Okay. Just a second. Let me.
Hello. We'll wait till 3:05 or 3:10, ma'am. Then we'll.
I'm actually not able to find that option.
Okay, Dr. Namrata, ये um, say for example, you click on Dr. Janvi's window. Okay,
Okay.
on the top right corner, you will be able to see three dots. वैसे ये
Okay.
लोग सभी host हैं, so I think it's no more showing. I think you
Okay.
all are host right now, so it's okay.
Okay, fine. Okay.
Yeah.
Hello, Aishi.
हाँ डॉक्टर.
How do we mute the other participants?
Uh, checking, I'm checking. Yeah, so automatically everybody is on mute, I feel right now. If you want to mute somebody, you when you click on the participants as a list, participants बोल के there is one icon. Yeah. So on that, if you click on the side, you can see the participants list. So when you do that, you can click on the mic, mute and unmute from there.
That I understood. Okay, I found it.
Yeah.
There's one, our clinical geneticist, Dr. Kaveri, she has to be given permission, it seems.
There is nobody in the window yet. Is there anybody? Can you ask her to try joining again? Sarah, once the session starts, no, we can't leave it. Though I have made them host. Okay, I made. Oh, there can be only one host.
Trying from two different links. Like I'm trying from two different IDs.
One minute. Ma'am, Namrata, ma'am, you're the host. Can you see if Dr. Kaveri is able to join? She's
No,
waiting.
no, I don't see anybody waiting in the waiting room. There's someone called Heta's iPhone who I just admitted, but there's no one else. Can you ask her to try and join again? You're muted, Janvi. Dr. Janvi, you're muted.
Yeah, ma'am. I'm talking to Dr. Kaveri.
Okay, yeah.
Dr. Janvi, this session is logged in as such. Okay. There is one other meeting that I'm getting into, but Sarah is here to, respond to if there are any more queries. She's here
Sure.
at the system. Yeah.
Sarah.
Yeah, Sarah.
Okay, sure.
Can you speak something, Dr. Janvi?
Hello.
Yeah, all right. For the website, sir?
Hello. Am I audible?
Yes.
Okay. Uh, Good evening, all. It gives us a great pleasure to welcome each one of you to this live PWS interactive session. So, we all know that we are celebrating the Prader-Willi Syndrome Awareness Month in May, and it gives us great pleasure to keep a live session this year. So, I would like to invite all our panelists. First, I would like to invite our consultant pediatric endocrinologist from Aster Whitefield, Aster CMI, and Aster RV Hospital, Dr. Namrata Upadhyay, who is a consultant pediatric endocrinologist at Aster RV and Aster Clinic, JP Nagar, Dr. Shruti Shastri, who is the consultant pediatric endocrinologist from Aster CMI and Aster RV Bangalore. We have a clinical and pediatric geneticist with us, Dr. Nemani Kaveri Lakshmi, who will be answering your queries related to genetics. I also want to, we will be adding few special points on the logistics and the conduct of our Prader-Willi syndrome multidisciplinary clinic. I welcome each and every one of you. We hope to make this session a very interactive one. So as we know, a Prader-Willi syndrome is a very rare genetic condition which is caused due to an abnormality in the chromosome number 15, especially in the paternal chromosome. So here we are here as experts. We would like to handle all your doubts. So I'm very happy that all of you had sent few questions and queries prior to this meeting, and we have tried to cover most of these questions. If we are not able to cover due to the paucity of time, we want to assure you that we will conduct such sessions in the future also. So regarding Prader-Willi syndrome, the most important thing which I want to say is the resilience of each and every one of you who have been taking care of your children. But I'm sure day to day you all are facing much queries, and hence we have planned this session. The most important point in Prader-Willi syndrome, which we would like to begin this session, is with growth hormone. As we all know, growth hormone is an approved indication, FDA approved for children with Prader-Willi syndrome. It has been here in treatment since 2000. So let us first handle a few queries, for which I would like to invite Dr. Namrata and Dr. Shruti Shastri. So first I would like to call upon Dr. Shruti Shastri. So, Doctor, how would, in your experience, based on your practice in children with Prader-Willi syndrome, when do you generally recommend growth hormone therapy? At what age do you start, and what do you recommend for parents of children with PWS?
Yeah, so Prader-Willi syndrome, as we discussed before, one of the characteristics of Prader-Willi syndrome is kids having a low muscle tone. This is because their mass of fat to muscle ratio is reduced, right? So growth hormone deficiency is present almost from the start. This is also due to some hypothalamic changes. Hypothalamus is basically a center that's present in the brain. So because of this, the brain typically makes growth hormone. So because some genetic changes that happen in the brain, there is growth hormone deficiency from the start. That you notice kind of floppiness even to begin with. So there have been plenty of studies that show that growth hormone is important from almost around 6 to 12 months. So the earlier we can start hormone therapy, the better, both the motor as well as the psychomotor, as well as reaching the milestones, as well as physical, mental, all of these outcomes will be much better. So the earlier that we started, the better it is. And this is typically, as soon as the parents bring the patient in, we start discussing. Probably between 6 and 12 months is an ideal time to start.
Okay, so I think we have two takeaway points. That is, the earlier you start, it is better. And the second point would be that it just does not benefit in terms of the growth, but it has multiple benefits in children with Prader-Willi syndrome in terms of the development, the tone, the behavioral issues, probably even hyperphagia also. So parents, let's take these 2 points. And now we'll go to the next question. So Dr. Namrata, a few of our patients, I think we've experienced, who tell that is it really necessary? So the other question which they ask is, what about the side effects? Most of the kids with the parents of the children with PWS are worried how long to continue, what are the side effects? Could you please talk on it?
Okay. Hello, everyone. Thank you, Dr. Janvi, for the introduction and having me as part of the panel. So to address the question at hand, as Dr. Shruti has already highlighted on the why growth hormone is necessary in anybody with Prader-Willi syndrome, because of the underlying, problem with the hypothalamus, which is a very major part which is affected in Prader-Willi syndrome. So it is presumed that children with Prader-Willi syndrome universally have growth hormone deficiency. So as a result of that, there is no need for formal testing for growth hormone levels like how we do for other children in suspected growth hormone deficiency. So to answer your question, yes, growth hormone is necessary for all children with PWS, and they definitely seem to benefit from treatment at whatever age the child has been diagnosed, or whatever age the child has access to get growth hormone. However, as Dr. Shruti has mentioned, the earlier it is started, the better is the effect. In fact, as you've already mentioned, growth hormone has been FDA approved and has been used as standard of care in Prader-Willi syndrome for the last 25 years. It's more than 2 decades. So we actually have an entire generation of kids having Prader-Willi syndrome who seem to have a different appearance, different quality, better quality of life, and healthier lives compared to their peers with PWS who could not receive growth hormone therapy for whatever reason. Isn't that? So coming to the side effects part of it, yeah, it is. It is a drug which is given externally in the form of an injection. So as with any other medications, there can be benefits as well as some risks involved. So, however, growth hormone therapy, the risk to benefit ratio, I mean, the benefits that you get out of taking growth hormone in a child with PWS far outweighs the risks that are involved. Having said that, there will be some precautions that will be taken, some tests that will be done prior to initiation as well as on treatment for growth hormone therapy. So I wouldn't go extensively into that, but a few common uh, problems that can be encountered are, there is an entity called obstructive sleep apnea, especially in more common in children with PWS. So if there is a child who is undiagnosed of OSA or any other respiratory problems, get started on growth hormone therapy without sleep study, they may have some worsening of these symptoms. So that is why it's a mandatory protocol that a sleep study is done before starting growth hormone therapy. So the other things are these side effects can be seen in anybody, but in children with PWS, there could be something called metabolic effects because of the positive effect of growth hormone on blood sugar. If the child is borderline, is a pre-diabetic, or even otherwise, it's possible that the blood sugars might rise, and there might be a chance for diabetes to worsen. So it's important to monitor for blood sugars and HbA1c before starting treatment, as well as when the child is on treatment. Growth hormone therapy can also unmask or open up previously undiagnosed other hormone problems commonly seen in PWS, such as low thyroid hormone levels, low stress hormone levels, which may not be evident before starting therapy, but these can worsen during treatment. So it's important to monitor for these. And more rare side effects include, uh, you know, uh, worsening of the curvature of the spine. Children with severe forms of scoliosis, once started on growth hormone, they may have a rapid growth, which can worsen their curve of the spine. So it's important to consult your pediatric orthopedician. And the other thing is there's an entity called benign intracranial hypertension, wherein the child might develop headache, vomiting, and blurred vision, which is usually common with high doses and in the initial few months of starting therapy. However, it's not that common of a problem. It's relatively rare. But however, it's important to know and be educated and be aware of it. But it can be treated. Most of these side effects can be detected and they can be treated. And there are very few conditions where absolutely growth hormone is advised not to be given. That is in untreated or severe respiratory problems. In any child who is known to have an active malignancy or cancer, in these conditions, growth hormone is strictly not advised. In all other cases, you can we will give you a clear guideline as to how it is to be started and what are the symptoms and signs that you need to watch out for. I hope this answers your question.
Okay, thank you, Dr. Namrata. So, I would like to just put it in a nutshell that it's very important you give consider growth hormone therapy. Prior to that, get a sleep study. Ask your pediatrician or a pediatric endocrinologist for a sleep study. And when they are on growth hormone therapy, make sure to keep checking the blood sugar and the thyroid. And if you notice any worsening of the the curvature or the way your child walks, or if your child complains of headache, vomiting, then see your doctor immediately. So I would also want to add that if you have any queries among any of these questions that we are asking, please feel free to put it in the chat box. So Dr. Shruti, we had one very nice question from the parents when we were collecting these questions for this session. So one of them wanted to know that the child is on the 75th percentile for the height. I think you have covered this in your previous question also, but they are concerned that just because the child is actually of normal height, should they really go for growth hormone? What do you think?
Yeah, so as I mentioned before, we are not utilizing growth hormone in kids with Prader-Willi syndrome just for the height increase as we do with other patients with growth hormone deficiency. So growth hormone does a number of things, So first I can start with like its effects from top to bottom. First, it works on certain like feeding centers in the brain. It can work on as I mentioned before, the muscle mass increases, which is the main thing that happens in Prader-Willi syndrome. And, think, yeah.
Yeah.
So the muscle mass or the floppiness, that is the main thing in Prader-Willi syndrome. So it increases the muscle mass and it reduces the fat mass. So that ratio kind of improves. The third thing is it improves general well-being and general feeling of health in patients with Prader-Willi syndrome. The other thing that I wanted to also mention is that in patients with Prader-Willi syndrome, they are growth hormone deficient. So, even if their height has been adequate at this point of time, we don't know what their final height outcome is going to be, and they will benefit overall, not just from the height increase. So, giving them extra growth hormone therapy is not going to cause them side effects as they are already kind of lacking in it, right? So if you're already having enough of growth hormone and on top of that you give additionally, then we think about side effects. But if you are lacking from growth hormone, you're actually suffering from the side effects of not having growth hormone therapy, right? So I definitely the patient, we can. The thing is that we are always monitoring these levels. It's not like we just decide one standard level and dose that's for everybody. So if the patient is on the 75th percentile, that's great. So we will also get a baseline, what we call an IGF-1 level. And IGF-1 level is a surrogate marker for growth hormone, because growth hormone is not so stable when you just take it from the blood. So IGF-1 is something that is like in place of growth hormone. This is something that we monitor. So we will check this first, and then we'll start them on growth hormone, and then we'll see what their IGF-1 levels are, moving forward. And in case that we are exceeding what it should be, if it's not within the range, we will always come back down on it. But it is important, for them to develop all of their milestones on time for their general well-being, for all patients with Prader-Willi syndrome to be on this medication.
Uh, yeah, so I think this is a big boost or a big motivation for you to go and request for growth hormones. See if your child is eligible or within the criteria, no contraindications for growth hormone, because growth hormone has multiple benefits, not just on the height. Even if the height is in the normal range, do not hesitate to go and request. So we'll just thank you, Dr. Namrata and Dr. Shruti, for this session on the growth hormone. Now I want to go into a very important aspect. So we cannot exclude the doubts regarding genetics in Prader-Willi syndrome, right? So we have our clinical and pediatric geneticist, Dr. Kaveri. Welcome, Dr. Kaveri. So, we always have a lot of parents have these doubts regarding will my next child get it, or which test should I do? Should I get tested? Should my husband get tested? So, first, I want to ask you, what is the genetic test that is best done to diagnose PWS, and when should it be done?
Um, Hi, Dr. Janvi. Good afternoon to everybody who's attending the live session today. So, I'm Dr. Kaveri. I'm a pediatrician and a clinical geneticist here at Aster Whitefield. So, I want to start off by telling that genetic testing for Prader-Willi syndrome, it is slightly complex because there are multiple steps to it. The first step is to confirm Prader-Willi syndrome, and the second and equally important step is to identify the underlying mechanism by additional testing. So what we usually do is a comprehensive test which covers both of these aspects, and it's called as MS-MLPA. So it identifies the abnormal methylation, number one, thereby confirming the PWS. And second thing it does is identifies the underlying mechanism, whether it is a deletion or a UPD, or although very, very rare, it also identifies imprinting center deletions. So when should the test be done? It is very simple. We have to do the test as and when we suspect Prader-Willi syndrome. So in the newborn period, if we have a baby with low muscle tone, poor feeding, not gaining weight, or later in the childhood, there is a child who develops excessive hunger, obesity, typical facial features, developmental issues, this is when we suspect and do a Prader-Willi syndrome testing by this test called as MS-MLPA. And the earlier we do the test, the better it is.
Thank you, Dr. Kaveri. So I think in a nutshell, MSMLPA, correct?
Yeah.
If parents, do you have any concerns regarding this? I think you should meet the geneticist and discuss regarding what to do further. The next question I wanted to know is, as I told in the beginning itself, if one child in the family has Prader-Willi syndrome, what about the risk of having another child? Probably the parents are expecting their second child. So
Correct.
what is your
So this
take
is
on this?
Yeah, so this is a very important question. So most of the kids with PWS, when they come for the consultation, the thing that they ask is, could our next child also have Prader-Willi syndrome? So the answer to this depends on the genetic cause of the Prader-Willi syndrome. So, but to put it in a very generalized way, if it is a PWS caused because of a deletion, which accounts for around 70 to 75% of the cases, and if it is because of a UPD, which is around 20 to 25% of the cases, that is more than 95% of the cases, the risk of the future pregnancies is less than 1%. And in certain rare cases, which are around less than 5%, the risk of repeating this problem in the future pregnancies can go up to 50%. So, depending on the subtype of the Prader-Willi syndrome, additional testing will be required for the family, and genetic counseling will become very, very, very important to assess individual risk for the family.
Okay, so though recurrence risk is rare in most of the types, there are few types which can have a risk, which just needs to
Yes.
be tested. So this maybe we can, it's a eye opener, I think, and we'll have to counsel the parents based on the type of the genetics which is identified in their child. So
Yes.
what about the differences in each genetic, like you mentioned, right, there are different types, genetic subtypes which can lead
Yeah.
to Prader-Willi syndrome. So what are the, is there any particular clinical features which are different in each of them?
Yeah. So, although all the Prader-Willi syndrome children need similar lifelong care, the genetic cause can slightly influence the clinical features and thereby the treatment, treatment and management that we should do. For example, like the deletion subtype, usually they have more hypotonia. That is, the muscles are more weaker in the children with deletion subtype. They have more typical facial features growing up. They might have more excessive hunger, thereby they have more obesity. The deletion subtype also is known to have more cognitive challenges and speech delays. So in this children, early intervention becomes very important. Speech therapy becomes important. Behavioral therapy becomes important. And the UPD subtype, that is the uniparental disomy subtype, although they have very good and like higher verbal IQ as compared to the deletion subtype, they have challenges during the adolescence. They have more mood issues. So it will become important to monitor them for this, and also they need to be monitored and like trained in their social cues. And as I already told, imprinting disorder, that is very rare. Although it's very rare, it has a higher risk of recurrence in the future. So in this subtype, mainstay of management and treatment will include genetic counseling, and it probably is at the top because the recurrence risk can go as high as up to 50%.
Okay. So I would like to add here from what we've heard from Dr. Kaveri, that today probably you can go back, see the genetic report of your child, find out what is the subtype, and come back to us or any of your doctors. See, there are many studies which have proven certain characteristics are more common in certain particular genetic subtypes. So if we are aware about it, early awareness can lead to better management. Thank you, Kaveri, for your wonderful insights. We'll come back to you. Actually, we have few questions in the chat box also. I will be handling all of them at the end of the session. But for now, let's go back to our pediatric endocrinologists. Apart from growth hormone, we are going to see the other things. We'll just go through a broad overview of the other things which we have to understand about our children. So, Dr. Namrata, you spoke about breathing problems briefly when you were talking about the sleep study and all that. So, what are the breathing problems in these children? As you told, you need to get a sleep study done. How do they tackle this?
Yeah. Uh, so as we know, again, the hypothalamus is the center. It's a part of the brain where, because of the missing genes in PWS, apart from the hormones, hunger, and other things, sleep is also an important part of life which is regulated at this level. So it's known that children with PWS have a lot of sleep-related problems. They have shorter sleep cycles. They also have, difficulty in falling asleep and staying in deep sleep. They have excessive daytime sleepiness, and they also have certain risks to develop disorders such as narcolepsy. That's where they have these sudden urges or tendencies to fall asleep even during the daytime while they are awake. So they are more prone to develop these kind of sleep problems than in people without PWS. Okay, so to remember, the things to watch out for are excessive daytime sleepiness, any abnormal movement or urge to fall asleep during the daytime, and difficulty in falling asleep and staying asleep as well. So apart from these, they have specific breathing problems which can happen during sleep, and this is called as sleep apnea. So there are two types of sleep apnea which we see in PWS. One of them is the obstructive sleep apnea, which happens because of the low muscle tone, the facial features, the tongue falling back while asleep, and also in older children, enlarged tonsils and adenoids. So they can obstruct or block breathing during sleep, because of which the child can have long pauses during breathing, during their sleep. Okay, so this is one category of sleep problem, and the other category is called central sleep apnea. This is especially common in very young infants, small babies, where because of the abnormality in the sleep regulation, the hypothalamus, they will just have pauses. They will just stop breathing in between during sleep. So the most important thing is to know here is sleep problems are often difficult to diagnose in children with PWS, and a lot of other problems such as heart-related problems and behavior problems in older children could actually be due to an underlying sleep problem. So by itself, it's a very extensive topic to discuss, but I would like to tell parents to watch out for some important things. The first thing is, before starting growth hormone, get a baseline sleep study done. Your pediatric endocrinologist or pulmonologist will guide you as to how it has to be done, and if needed, they may give some you may have to use some tools to help your child to breathe, such as a positive pressure, a CPAP, or a BiPAP machine. So that is one of the things. The second thing is to watch out, to have a very structured sleep routine. Okay, have a routine or key as to maintain the sleep time, sleep and wake cycles for your child very strictly, whether it's during weekends, holidays, or otherwise. Have a sleep friendly environment, that is, have a room which is dark, cool, and away from distractions. Do not give any screens, no screen time for at least 1 to 2 hours before the bedtime. So this is something which can be started very early in life, and it will help to prevent as well as detect any sleep problems. The other thing is, as your child grows, if you notice that your child is snoring too much, is breathing is pausing for a long time during their sleep, they're not breathing for a long time during their sleep, or if you notice that there is any sudden change in their behavior, or they're sleeping excessively during the daytime, or they're having abnormal movements such as jerking, or head bobbing, or they are just falling off while they are talking, or when they are emotionally excited, these could all be symptoms suggestive of narcolepsy. So it's important to tell your doctor at consultation, although we in our clinics we routinely have questionnaires and tools to screen them. So these are the things to be kept in mind, and treating a lot of sleep problems could actually change the quality of life of a child with PWS.
Thank you, Dr. Namrata. So parents, not just, the sleep study before starting growth hormone while breathing, or excessive snoring, or daytime sleepiness, or falling while like standing and sleeping. All these are also issues which needs to be handled in children with PWS. We got a few tips on how to handle them, but always meet your expert also. So, Dr. Shruti, like apart from sleep, or apart from growth hormone related stuff, what about the other, like other hormonal issues like puberty? What happens and how to monitor them?
Yeah. So puberty is another very important endocrine issue that comes up in patients with Prader-Willi syndrome. So first, in infancy itself, almost around between 80 to 90% of the males will have what we call cryptorchidism, or undescended testes. They also typically will have smaller genitalia. And coming to the females, they will have a smaller clitoris, as well as they can have a smaller labia minora. And then as they grow older, the main question comes up is to when will they develop puberty? Will they develop puberty like on their own, or do they need the help of an endocrinologist to start off with puberty? So based on most of the studies that we have, it looks like they both males as well as females are able to start puberty spontaneously or on their own. But in males around the age of around 13 and a half years, it kind of stops progressing further. So they end up with lower what we call testicular volumes, or the testes itself is kind of underdeveloped, and it doesn't make enough of the hormone testosterone. And in females, even though a lot of them will go through puberty normally, in the sense that they will have breast development. Actually, they may even develop this on the earlier side, what we call precocious puberty. And some girls might even start off having periods on their own, but around 15 and a half years, they also kind of stop progressing further. And later they might need some additional hormonal supplements. So first, coming to the males, although there's no kind of what we call consensus guidelines on, should we start therapy at a certain age, or at what age do we start this? What therapy do we start? Because of a lot of studies that we have done and information that we have based on what we call the clinical expertise based on the patients that people have seen. Generally, they do recommend starting on some testosterone replacement. And again, that can be a discussion between you and your pediatric endocrinologist as to when you feel it might be most beneficial to start it. But around 15 to 16 years of age, it's been shown that testosterone levels kind of start going down, and might benefit from getting, just a small monthly injection of testosterone. Again, because there's no specific guidelines to tell us how to do this, we can base this off of how your child is progressing and go from there. But the main benefits to having testosterone is, first of all, the PWS patients already have the low muscle mass and the tone and everything. So this testosterone might kind of be additional benefit to that. It can also, to help a little bit with the muscle mass, it can also help with, general mental and physical well-being as well. And although it is, coming to a later stage, when they are ready to, or if they're at a phase that they want to have children or whatever, it's very difficult and I think there have been no documented cases so far about males having had children, males with Prader-Willi syndrome having children. I still think that the testosterone will be beneficial in the long run. Coming to females, they, even though they do, some of them may start off with their period, some of them may not, and if they don't, we might have to start off estrogen therapy, and this, we will do slowly and gradually. We'll have to add on the two main female hormones that we see during puberty, which is estrogen as well as progesterone. And again, I don't want to get into too much of details about this, because it's going to depend on each specific case. But we will be measuring the hormone levels in your child, and then we will be starting the treatment accordingly. And again, it's going to be case based, if they're going to need it lifelong, or if they're going to need it, just for a short period of time. In females, especially, the studies are a little bit more sparse. But I mean, that's the main, females have been shown, there have been a few females that have been shown to get pregnant spontaneously. So, fertility is not as much of an issue in the females compared to the males. But again, hypogonadism is very, very common in both males and females with Prader-Willi syndrome, and can be present in, almost all, about 80%, 80-90% of the cases that we see.
So probably each one of us should be aware that each child is going to be different, and whether the child needs puberty treatment, or whether they will undergo spontaneous puberty or not. But all that you must be aware is that get your child checked by 13 to 14 years of age, either it's a girl or a boy. And there are, we can, on a case to case, or a child, based on the child's condition, we can prescribe the hormonal replacement if required. Okay, thank you. So now, nutrition, I think, plays a very important role in Prader-Willi syndrome. All of you may know that initially they will not be able to gain weight, but later on, they will be, starting to put on more weight. So, how do we explain these changes, and what are the challenges? Dr. Namrata, if you could handle that question.
Yeah. So as in PWS, again, in somebody without PWS, the appetite as well as the feeling of fullness, the feeling of hunger and fullness are balanced in such a way that we don't really realize it. But in PWS, there is this ratio is skewed, or this balance is lost. So what happens? How does this manifest? So in the early stages of life, such as in utero, or in the first 1 to 2 years of life, so there is a lot of decrease. The appetite is really low, and the because of which these children may be born. About 30% of children with PWS may be born low birth weight because of this reason. And during infancy, they continue to struggle to gain weight, which is partly because of the low muscle tone, of the feeding difficulties, and the excessive sleepiness that is associated with PWS. So this is called as nutritional phase 0 to 1. There are usually 4 major nutritional phases through which children with PWS go through. So as they cross the first year of life, and sometimes in the early second year, they begin to their appetite kind of begins to improve, and their feeding is better, and they're developmentally they're slightly better. They're able to take foods and all that, but however, they may still not gain as much weight as they're expected to. But in the second half of the second year, they usually kind of their weight kind of stabilizes, whereas their appetite is normal, and their weight gain is also steady. So usually from the third to fourth year onwards, there is the entity called hyperphagia. That is the increased interest in food, increased appetite, increased consumption of calories that can happen in these children. So also one important aspect that we need to know is a child with PWS, when compared to a child without PWS, even though they're of the same age, even if they're given the same amount of food, the child with PWS tends to gain weight faster. This is partly because of the abnormal body composition, the ratio of the muscle and the fat tissue that is there. So this is something which we need to keep in mind while advising nutrition to a family with a child with PWS. So the hyperphagia usually sets in by the third year of life, and if unchecked, if not treated, these children can put on weight very rapidly, and they may become overweight and obese, and that can lead to problems. Usually hyperphagia once sets in, it kind of continues until adulthood. There is some research to suggest, there is some evidence to suggest that some percentage of adults may actually, the hyperphagia might come down in their third to fourth decades of life. However, the percentage of this is very variable. So the key take-home message here is that the nutritional needs keeps changing from infancy to adolescence to adulthood. So it's important to have your child's growth tracked on a growth chart, especially the second, between the first and the third stage. The change cannot be picked up by you or me without a growth chart. It may be difficult for even the parents to know whether their child is really eating well, or eating normally, or eating more. However, we have the child's growth records on the growth chart. It will give us an indication as to whether this child is progressing from one nutritional stage to the other. So this is what I would like to emphasize on, that whenever you visit your pediatrician or your pediatric endocrinologist, please have your child's weight and height and weight for height recorded on the growth chart, and discuss with them what changes in the child's diet you need to make. So that's an important thing to note down.
Thank you. I think that was very covered in very simple terms. You must have understood what you should follow and what you should keep in mind when you're going to meet your doctor. So, as Dr. Shruti, that now that we know that calorie restriction in these children due to the differences in the body composition, what do they need to be supplemented with any vitamins or minerals, or what is the guidelines or the expert advice on this?
Yeah. The one thing that we have found out, studying all the patients with Prader-Willi syndrome is most of them suffer from vitamin D deficiency. I think there's a couple of reasons for this. The first is that we already know the obesity comes into play in most of the patients with Prader-Willi syndrome. And when there is increased fat mass, there is some resistance to the vitamin D, and they require more vitamin D. So, having the levels checked and starting with the supplementation will be beneficial for most patients with Prader-Willi syndrome. The second thing is that I think about 80 to 90% of the general population is itself lacking in vitamin D deficiency, just because in the older days, or in the older generations, we were much more exposed to the outdoors. Now most patients just kind of, or most people just kind of like, sit inside, apply sunscreen, so because of that itself, most of the general population itself is lacking in vitamin D. So that is one thing that Prader-Willi patients should be aware of. The other, things are not here or there. So there have been some studies that show that calcium deficiency can be present in some patients with Prader-Willi syndrome, especially because of the decreased muscle, as well as the bone density sometimes can be a little bit affected. But again, it's best to have this checked before you start off with the supplementation, just on your own. Some studies have shown in certain populations about iron deficiency, but again, that's not been consistently shown in all the populations. So this is again something that should be checked before we start off with any vitamins or supplements and things like that. But it is going to be very important for you to work with a good nutritionist or a dietitian, because we do recommend having a lower calorie diet in these patients. But lower calorie, should not mean that it's deficient in nutrients, right? So it should be micro and macronutrient rich, fiber rich, as well as low in calories. So it's going to be a delicate balance of making sure they're getting the right amount of micro as well as macronutrients. So it's best to have your child tested to see if any of these deficiencies are present. I mean, those are the key takeaway points, are to have to have them tested. Vitamin D, most of them will be having deficiency, and to work with a nutritionist to come up with a good diet plan that's to have a nutrient-rich diet.
Yeah, thank you. So, what about we'll go to the very important aspect in these children. How do we tackle hyperphagia? I think hyperphagia and physiotherapy, that is the infant who are floppy, these are two important aspects that we should take care of. I would like to touch upon those topics. First, Dr. Shruti, how do we tackle hyperphagia? After that, we will go and see how to do floppiness and physiotherapy.
Yeah. So regarding the hyperphagia, now again, the hyperphagia, as we have discussed in this webinar previously, happens because of disturbances in the brain, or the hypothalamus, or the feeding center in the brain, because of genetic disturbances. So it's not your fault that you didn't give them a proper diet, or we did this and that. Don't blame yourselves for it. First, it is because of these changes in the brain itself. So unfortunately, this hyperphagia, or this kind of food seeking behavior, will last kind of like throughout their lifetime. So from the beginning itself, there are three ways that we can tackle this, right? The first and most important way that are shown to have clinical results is diet as well as behavioral changes, right? So, of course, as I mentioned previously, we need to have a low calorie and nutrient, fiber and protein rich diet. The second is exercise or physiotherapy is going to be also like very important to maintain the weight in a stable range. And the third thing that we can do behaviorally is you have to be kind of hyper vigilant, unfortunately, of this eating behaviors, in the sense that you have to they seek out food, right? Like anywhere there is food, they're going to go and they're going to want to eat it. So just make sure that you don't have any food that's available to easily reach or eat at home. I know that some patients of mine actually, like, lunch is done, breakfast, they give them a certain restricted amount of food, in certain times, and then after that breakfast is done, lock the door of the kitchen, no entry to that. Give them lunch. Again, you should be in charge of how much food that you're serving them, right? So you need to give them controlled portions, don't give them anything more, one serving and that's it. So lunch is done, lock the kitchen, and the dinner is given, and then you lock the kitchen. So to be hyper vigilant of where they're getting their food from. It is going to be difficult, of course, when they're outside and things like that, but as much as possible, you have to be vigilant of their food seeking behaviors from the beginning itself. When they start solids, even starting around like 8 to 12 months or whatever, just make sure that you tell them that if breakfast is at this time, that's it, you just get one portion. So that way it kind of sets the expectation that they're not going to be eating in between meals, and how much it is, that much it is. You're not going to ask for second servings and things like that. So this is regarding diet and behavior and things like that. The second one is medications. I think that this is also something that a lot of parents will be asking these days, because there are certain weight loss medications that are on the market, but none of them have been shown to be very useful. None of them have been shown to be like very useful or successful so far, but there is a new medication, that's on the market, known as Vicat, or diazoxide choline controlled release tablet, which is a once a day tablet. Of course, it's just been FDA approved in March of 2025. And this works on that appetite center control in the brain, to reduce the appetite or the hunger hormones that are being produced in excess in patients with Prader-Willi syndrome. So that is something, to watch out for. People think that this might be kind of a game changer, but it's not, of course, it's not come to India as yet, and hopefully it will be in the market soon as well. So medications, there are other medications. People might ask about what we call GLP-1 agonists, or your generic is like your liraglutide, semaglutide, or Ozempic, some medications like that. Again, those can help to a certain extent, but not as much. And then the third, there are other fat loss medications, but again, none of them have been too successful. The third one comes to surgeries, so bariatric surgery, gastric bypass surgery, and things like that. Again, might not be super successful, but might help to a certain extent. So I think all this takeaway point being that the main thing is to maintain mealtime routines, and to avoid the avoid the food seeking behavior. These are going to be your mainstay.
Thank you, Dr. Shri. I think you covered I had two questions about GLP-1 agonist, liraglutide, which parents had specifically asked, and the other one about the recent advances for hypophagia, which is a new FDA-approved drug. So we have covered that. If you have any further doubts, I think we can discuss with you in person separately because they're all upcoming drugs and have not been. They're just the FDA approved ones. Okay. Dr. Namrata, just two last points. Like, what about exercise in children with Prader-Willi syndrome? We know that as young infants, they are going to be floppy, and we need to give them specific physiotherapy. What about older children and the exercise in them?
Yeah, exercise is a very important part of life for anybody for that matter, especially in children with PWS because of the obesity and the low muscle tone. They're naturally their muscles are not burning enough calories, but exercise can help them. In addition to the effect of growth hormone, can help the capacity and it can build their stamina as well. So the most important benefits of exercise are, of course, on our cardiorespiratory health. Their hearts and lungs are going to be fitter and stronger. The children are more likely to lead independent, healthier lives if they are physically active right from the beginning. The other thing is you can keep lifestyle diseases, mainly diabetes, high blood pressure, at bay. Or as more and more of people are being prone to these kind of disorders, and exercise, physical activity also helps with cognitive or thinking, and it also to some extent helps to manage some behavior problems. However, it can be a challenge in anyone, more so in a child with PWS, to get them motivated to be involved and stay physically active. So I'm going to just give a few tips to start. One thing is start early and take advantage of the fact that children with PWS prefer to stick to a routine. So they have a stickler for routines, and they're more likely to adhere to something if it is part of their day and if they're doing it repeatedly day after day. So take advantage of that and set aside a time of the day for physical activity alone. So, and maintain that and be consistent with that. So the second thing is, you need to choose activities which your child enjoys. So exercise it has to be made fun as well as engaging. So it's only when the child enjoys doing that activity will they really be you're likely to get them to do the exercise and see the benefits of it. So it could be anything in the form of sport, it could be running, it could be a throw ball, it could be swimming, it could be martial arts, or even dancing and aerobics for that matter. So choose an activity which your child is most likely to enjoy and keep rotating it so that the same activity bores them down. So you need to have a structure. You need to have a few activities which your child will enjoy and keep rotating that. The other thing is the family also needs to be involved. So make it a family activity and make it a group activity. If you're going to model the activity yourself, your child is more likely to adhere to that. So involve a lot of group activities at home on a daily basis, or even outdoor activities, as a part of your child's lifestyle as well. The other thing is, yeah, we also need to consider some limitations that children with PWS might have, especially if they have some problems related to hypotonia or weak joints, knee pains, and things like that. They may not be able to take part in different types of activities. So it's important to know what their limitations are and stick to that. And also involve them in daily chores, involve them in any daily activities like, going down and fetching something, going up to the terrace and getting some things. So that keeps them physically active as well. So again, it's important to be consistent and have something or the other every day. So don't give up if you're not able to get your child to exercise for 1 or 2 days for whatever reason, but be consistent and stick to the routine.
Thank you. We'll just shift a bit from the concerns about, the endocrine concerns or the sleep-related concerns. So I want to bring in a next topic here, that is about the conduct of and the importance of Prader-Willi syndrome multidisciplinary clinic. Why we are bringing it here specifically is that Prader-Willi syndrome is a rare condition and it requires multidisciplinary care of all departments, not just focus on one particular area. So we have conducted such multidisciplinary clinics. And as our endocrine coordinator, I want to bring in Mrs. Vinita Prabhat, who has done her MBA in hospital administration. So I want you to hear from her regarding the operational logistics regarding this clinic. Vinita, welcome. So let's just give parents an overview. What challenges did you face when these clinics were conducted, and how do you think it was, tackled?
Thank you, Janvi ma'am. One challenge was assembling a team of specialists who is expertise in PWS. As it is a very rare condition, we were facing many challenges. We overcame this by meeting the specialists from different departments, and we gave them the specialized training at our center. And we have also partnership with PWS organization in India as well as abroad to better understand the patient needs.
Okay, so the point she said has stressed importance have trained experts aware of this rare condition. And so how do you think, because we have few new parents also as well, how do you think in the future we are going to help them or make it better?
We think the way forward we can develop a hybrid models combining in-person evaluation as well as the online consultation for follow-ups, which is like it will be very easily accessible, and all India patient registry track can also be done, so it will be helpful, income will be more, and our main focus is on providing a world-class center in PWS with the focus on patient care and supporting the patients throughout their lifespan.
Thank you, Vinita. So I think the center of focus is patient care, making Prader-Willi syndrome a patient-based centric approach.
Yes.
I just want to cut short and go to genetics for one last question, which I think it's a very practical question, and I hope it would help parents. Dr. Kaveri, at what age do you think that we should disclose this condition to parents? When should they speak to the kids with Prader-Willi?
Yeah. So, the best time to begin your talk about Prader-Willi syndrome with your children is when they are developmentally ready to begin to understand their condition, which is usually at around 4 to 8 years. So you need to start with the basics and then you can build on it and as they grow. So start at around 4 to 6 years because this is the age when they start to notice differences between themselves and the others. So use basic languages like your body works a little differently. You might feel hungry a bit more often than the other kids. Focus on helping them understand their routines, such as like meal schedules, and help them to feel a bit strong. And usually by the age of 7 to 10 years, kids begin to ask more questions and they want to understand why things happen a certain way. So this is the time we need to introduce the term Prader-Willi syndrome and explain that it affects their hunger, muscles, and sometimes even their behavior or learning. So focus on empowering them by telling them that this is something that we can all manage together. And once they get to their pre-teens and teens, this becomes very, very important because now they are more self-aware and they might feel that frustration and like they feel the social differences even more deeply. So this is the time we need to be very honest and open about the challenges of PWS, including the food control, the growth, emotions, and frame it around the self-care and self-advocacy. So we need to build trust, confidence, and now we need to also involve them in making their health decisions. So to summarize, we need to start early. The conversation has to be age appropriate and adjust the message as they grow and add on information as they grow forward. And let it be an ongoing conversation instead of single big reveal. And always, always reassure them.
Thank you. So I think involve your child when as they're growing into teen and adulthood, involve your child in all the decision making. They do well with routines. They do well if visual cues are given to them. That is, if you show them anything, it goes better in these children rather than telling them something. And to tackle the behavioral issues, also sit with them, talk to them, and do not, these children, if you give them too many choices, they get, lost. So don't give them too many choices. Give them in such a way that it's a win-win for you as well. Okay. Thank you, all of you. I think we have come to almost the end of the session. Before we complete, we'll have a rapid round with the questions in the chat box. First, Dr. Shruti, regarding growth hormone, one of the parents wants to know if there are any other medications apart from growth hormone that can help improve the muscle mass, and what happens if they start in the middle age, like they didn't start in the beginning, they start growth hormone in midway or stop it midway.
Yeah, so good question. So growth hormone itself, the earlier that we started, the better the outcomes are. But again, there's no harm in, I mean, as early as you can start it. But if you haven't started it far and want to start it at this point of time, that's also totally okay. The benefits might not be as much, but you will see better benefit than not starting it at that point as well. The other thing that can help to improve muscle mass, medications per se, in boys later on, when they're in their pubertal ages, testosterone has shown to have some minor effects on it. But there's no other specific medications that has been shown to increase the muscle mass as much as growth hormone has. But the one thing that you can do that will be especially beneficial is physical therapy, and that needs to continue throughout life. So the more growth hormone in conjunction with physical therapy that you do, the more kind of weight training, resistance training that you do, the more it will improve your muscle mass.
Thank you. Dr. Kaveri, regarding the test for the risk regarding the next child, when should they get the test done?
So ideally, we need to do the testing in parents immediately after Prader-Willi diagnosis, or at least before the planning of next pregnancy. Is it required for everybody? It is especially required if the PWS is because of an imprinting defect or sometimes a chromosomal rearrangement. Okay, it is complicated, but in certain cases, the recurrence risk is very high. It's up to 50%. So in these cases, they definitely have to test. So ideal time is definitely after the diagnosis of the child, but at least before planning the next pregnancy, this has to be done.
Okay. Dr. Namrata, one of the parents are asking, how many times should a sleep study be done in a year?
Yeah, so the first sleep study ideally has to be done before starting the growth hormone therapy, the baseline, and then subsequently about 6 to 8 weeks after starting growth hormone. And if that seems to be in order, then if resources are available, at least an annual sleep study is what is recommended while on growth hormone therapy in any child with PWS. In addition, if there is any change in the sleep-related problems, if the child is having symptoms of obstructive sleep apnea or excessive daytime sleepiness or any sleep-associated behavior is seen, then that might be an indication to repeat the sleep study. Your pulmonologist or sleep specialist will be able to guide you better about this.
Thank you. Dr. Shruti, early signs of hyperphagia. If I have a 3 or a 4-year-old child with PWS, what is my early signs?
Yeah, so typically the hyperphagia doesn't start till about 4 or 5 years of age, but you will notice things like food-seeking behavior, like you leave anything around, the child has gone and gotten into the food and is eating it. Sometimes there might also be what we call food stealing or food hiding behaviors, like you might notice wrappers of whatever the sweet eat or the snack that is under their bed, they're trying to hide it from you. But you will know when they're eating much more than they were previously, and also trying to kind of hide it from you. They might also go to, like, when they go to some friend's place or some relative's place or something, they might go out there and start immediately going to the kitchen and taking out food and things like that. But typically this starts around 4 to 5 years of age, is when it starts appearing.
And I think they also start having a lot of food related thoughts. They keep on asking for food. All these are probably, we can look out for those. And so that's the thing they say, stick to a routine. It gives them no doubt that the food is going to come to them next at these particular times, so they don't get distracted. Dr. Kaveri, last question. What are the in uniparental disomy? I think you had it in the particular question. Just once more, what to look in children with uniparental disomy? That is, what specific features are more common in them?
Okay, so in uniparental disomy, they have higher risk of mood disorders such as anxiety, psychosis. For example, especially they start in the adolescence, so they can have hallucinations, paranoia, or something like that. They have good verbal skills, but they might struggle with social, behavior. For example, they talk well, but they don't really get the social cues. So that might lead to isolation, frustration, these things. Along with this, they also are known to have some trouble with abstract thinking, mathematics, problem solving. Although they're really good at like vocabulary, reading, they have a good memory, but this is what they struggle with.
Thank you. Dr. Namrata, the last question. Any specific diet you would recommend for these children?
Yeah, a very good question and a very important question. So as such, there is no specific diet for PWS, but it's being aware of the different nutritional stages, right from infancy to adolescence to adulthood, is important, as their nutritional requirements keep changing through these different stages. So in the first year of life, the child needs to gain weight, and we recommend a lot of high calorie foods as well as techniques to help improve feeding, especially in those children who have feeding difficulties. So as the child grows older, as I already mentioned, so a child with and without PWS of the same age, although they may look similar, the calorie requirement of a child with PWS is about 30 to 40% less than what a similar aged child without PWS would require. So it's important to make sure that we have reduced calories, but it has to be compensated, balanced with appropriate amount of protein content and fat content. So you could discuss this with us, your pediatric endocrinologist or your nutritionist, to help tailor make a specific meal plan for your child. It's not only about the diet, but it's also sticking to the meal times, sticking to the routine, and incorporating food security measures. That is, when it comes to PWS, food creates a lot of stress and anxiety for these children by the nature of the underlying problem. So no doubt, there should be no doubt that food is going to be available at this time every day. And there should be no hope that food is going to be available outside of these meal times. And also there should be no disappointment. This means that food should never be used as a reward or punishment for children with PWS, as this can go a long way in helping and managing a lot of behavioral problems that they can encounter. So please do discuss the feeding requirements and nutrition requirements at every visit with your doctor, and they will be able to help you out better with this.
Thank you. So I think Mrs. Priyadarshini, you can, Dr. Namrata has covered your question as well. How do we assess the calories? You can take the help of the endocrinologist and nutritionist. So they will teach you how much calories is required, and probably they will give you an idea that this cup, how much cups or how much spoons or how many meals in a day, what is required for your child based on the stage, nutritional phase your child is in now. Okay, due to the time, I think we started 10 minutes late and now we are at 4:15 p.m. I thank all of you for joining us in this wonderful interactive session. We had wonderful experts, Dr. Namrata Upadhyay, Dr. Shruti Shastri, Mrs. Vinita Prabhat, our coordinator, and Dr. Kaveri, the geneticist. Thank you all for your wonderful insights. I'm sure our parents have much more doubts and queries, but due to the lack of time, we'll end it here. Any last words from any of our experts?
Thank you so much, Dr. Namrata, Dr. Shruti, and Dr. Janvi. This was a very nice session. I personally learned a lot attending this session. Thank you so much for coordinating and putting the effort, Dr. Janvi.
Thank you.
I just want to quickly, I don't want to leave any of the any of the parents in the chat box hanging. I think there's just a couple of questions that are there. I quickly address it. So one is till what age should growth hormone continue? So that one we can, might be needed even lifelong because growth hormone deficiency is needed not just during the time of growth, but it might also be needed as an adult. Also, you still require a little bit of growth hormone. So that is something that I wanted to mention. And do PWS kids develop autism as well? So there is an increased prevalence of autism or obsessive compulsive disorders and behaviors in these patients. It doesn't mean that everyone has to have the characteristics, but they are at an increased risk of being diagnosed with autism as well. Janvi, I don't know if you wanted to add.
Thank you, Dr. Namrata.
Thank you, Janvi, for moderating this session so wonderfully. So I know time is always a constraint. So we're always available at Aster Hospital if you would like to come visit us and discuss any of your concerns. So I understand PWS is a lifelong condition, but nobody has to face it alone. So we are there. We are planning to build our multidisciplinary team, and we hope to make it better every year. Thank you.
Thank you. Ms. Priyadarshini, we will, if you all are interested, we can clarify or put together further like sessions and to discuss in the future. Doctor, I think there was one more question in the chat box, just the last one. What about starting the treadmill walking for 3.6-year-old child? How much is it safe? And would anyone want to
Yeah, I mean, for a 3.6-year-old child, definitely, I don't think treadmill is a safe way to start exercise. I mean, I think at that age, the child is hardly able to balance himself and herself. So I think it's better to involve them in active play. Take them to the playground. Get them introduced to different kind of activities which is age appropriate. It could even be dancing. It could be football or just running around in the ground. So just focus on getting them used to a certain routine in terms of their physical activity is what I would suggest.
Thank you. Thank you all. It was a wonderful session. Look forward to much more meetings and interactions with all of you.
Thank you, Janvi.